Good day, everyone. Today we're going to talk about heparin-induced thrombocytopenia. First, we have to know what is heparin-induced thrombocytopenia. Well, it is the development of thrombocytopenia due to the administration of various forms of heparin and some anticoagulants. HIT, heparin-induced thrombocytopenia, predisposed to thrombosis, the abnormal formation of blood clots inside a blood vessels. And when thrombosis is identified, the condition is called heparin-induced thrombocytopenia and thrombosis. Now we're going to see a video.
Hey, this is Dr. K from Medical School, and today we're going to talk about heparin-induced thrombocytopenia, otherwise known as HIT. So the first question is, what is thrombocytopenia? Thrombocytopenia is a fancy term that means a low platelet count. Platelets are fragments of larger cells found in the bone marrow called megakaryocytes. The function of platelets is to help form clots to stop bleeding. Now, heparin-induced thrombocytopenia is when heparin, an anticoagulant agent that we really use commonly in the hospital, leads to a drop in a patient's platelets. Now, there are two types of heparin-induced thrombocytopenia. There's type 1 heparin-induced thrombocytopenia, which is a non-immune mediated process. In some people, heparin causes platelet activation, leading to a partial consumption of platelets. If you continue the heparin, the platelet count returns to normal within a day or two. Now, type 2 heparin-induced thrombocytopenia is an immune-mediated process and will be our focus for the rest of this discussion. So, type 2 HIT involves the formation of heparin platelet factor 4 complex antibodies. We will discuss how these antibodies play a role in the development of immune-mediated thrombocytopenia a little bit later. But keep in mind, HIT type 2 is a very rare disorder and can lead to thrombi, including arterial thrombi, that are very platelet rich. Of all the patients you see, only 5% are likely to develop HIT who have a prolonged exposure to heparin. An important point to note is that your patients on unfractionated heparin have a higher risk of developing HIT than if they're on low molecular weight heparin. Risk factors for immune-mediated heparin-induced thrombocytopenia include a long duration of exposure to heparin, exposure to unfractionated heparin, being female, and a history of recent surgery. So let's discuss the physiology of HIT. Platelets have a receptor called a platelet factor 4 bound to their outer surfaces. When heparin is introduced into the bloodstream, the heparin binds the platelet factor 4 receptor. Generally, if a patient had a previous exposure to heparin, they may have developed an anti-heparin platelet factor complex antibody. This antibody binds the heparin platelet factor complex. The heparin PFR or platelet factor receptor antibody, when bound to its target, can activate other platelets. So the activation of platelets can lead to thrombi or clot formation, as well as consumption of these platelets by the body. Now that we've gone over the physiology, let's talk about how to diagnose heparin-induced thrombocytopenia type 2. If a patient with a current exposure to heparin has a 50% drop in their platelets after 5 to 10 days of exposure, this would indicate this patient likely has HIT. Now keep in mind, this time frame may be shorter if they had a previous known exposure to heparin. Other important findings that are indicative of HIT is if your patient develops a reaction to heparin. These reactions to heparin include necrotic skin lesions, tachycardia, dyspnea or difficulty breathing, chills, and fevers. Remember that patients with HIT are hypercoagulable, so thrombi can develop. Thrombi include DVTs, PEs, otherwise known as pulmonary embolisms, limb gangrene due to arterial thrombi, and finally, cerebral sinus thrombosis. The serotonin release assay is the gold standard for diagnosis of HIT type 2. The way the serotonin release assay works is that you take your patient's serum, who you suspect has HIT, and mix it with platelets that have a radio-labeled 14-carbon serotonin. When these platelets are activated, they release the serotonin with the 14-carbon radio label. The radio-labeled platelets are mixed with your patient's serum, and the combination exposed to heparin. If your patient has HIT, the heparin will lead to activation of platelets and release of the 14-carbon serotonin. If the radiolabeled 14-carbon serotonin is detected, then you have a positive serotonin assay for HIT type 2. Another test used to detect HIT type 2 is the platelet aggregation assay. In this assay, we take normal platelets and mix them with the serum of your patient with suspected HIT. We then introduce different doses of heparin into 3 samples. If the patient has HIT, then at low levels and at therapeutic levels, there will be low aggregation and high aggregation respectively. At high doses, no aggregation occurs as the heparin PF4 antibodies become overwhelmed. Now that we've discussed how to diagnose HIT type 2, we will discuss treatment. If you suspect a patient has HIT, stop all heparin injections and products. Keep in mind, certain devices may be lined with heparin, so just stopping their injections for DVT prophylaxis may not be enough. Given these patients are hypercoagulable, they need to be started on a direct thrombin inhibitor, like argatroban or bivalirudin. Argatroban has the ability of being able to be used in renal insufficiency and hepatic insufficiency, while bivalirudin generally can be used in hepatic insufficiency. Do not start warfarin or low molecular weight heparin for anti.
Signs and symptoms about the heparin. Heparin may be used for both prevention and the treatment of thrombosis. It exists in 2 main forms: an unfractionated form that can be injected under the skin or through an intravenous infusion, and a low molecular weight form that is generally given subcutaneously. It means administered under the skin. Now we're going to see another video.
Heparin-induced thrombocytopenia, or HIT, or HIT, we sometimes refer to it as, is a severe immunologic reaction to drug that can occur in up to 5% of people following exposure to heparin. Somewhere between 360,000 to 600,000 people can develop heparin-induced thrombocytopenia. The serotonin release assay, or it's referred to as the SRA, is considered the gold standard test for serologic diagnosis of heparin-induced thrombocytopenia. It's a very difficult test to perform. That's why it's important to use a laboratory that has experience with the test.
Blood Center's been doing this test for more than a decade on a routine service basis, and is one of the few laboratories in the United States that does this test in sufficient volume to be sure about the quality of the results. Another plus about Blood Center services, of course, is that we have a number of physicians and other experts available who have been working with HIT at a research level and a clinical level for many years, and are available without extra charge to referring physicians for consultation when necessary.
We wanted to find an entity that had expertise in the functional assays to detect HIT. And the Blood Center of Wisconsin actually provided that expertise. One of the benefits of using the Blood Center of Wisconsin to assist us in HIT diagnosis is now we've got access to the functional SRA, which is the gold standard. It has a very high sensitivity and specificity. So if we have a positive result, then we are very confident in the fact that this patient likely has clinical HIT. The 24-hour turnaround time that we were given by the Blood Center of Wisconsin is extremely important, because many times we were in situations where we were delaying a surgery just to be sure that the patient did or did not have HIT. One of the reasons why we chose the Blood Center of Wisconsin is because of the level of expertise that would come along with the assays. Now that we are using the Blood Center of Wisconsin, I feel that we are providing the best patient care possible to make sure that only those patients who truly have clinical HIT are actually being given the diagnosis of HIT.
What is the mechanism of heparin? Well, heparin occurs naturally in the human body, but the development of heat antibodies suggests heparin may act as a apten and thus be targeted by the immune system. In HIT, the immune system forces antibodies against heparin when it is bound to a protein called platelet factor 4, PF4. These antibodies are usually of the IgG class and their development usually takes about 5 days. The IgG antibodies form a complex with heparin and PF4 in the bloodstream. The tail of the antibody then binds to the cellular receptor, F cellular receptor, a protein on the surface of the platelet. This results in platelet activation and the formation of platelet microparticles, which initiate the formation of blood clots. The platelet count falls as a result, leading to thrombocytopenia. Now we're going to see another video. Now we are going to see about diagnosis. HIT may be suspected if blood tests show a falling platelet count in someone receiving heparin, even if the heparin has already been discounted. Professional guidelines recommend that people receiving heparin have a complete blood count on a regular basis while receiving heparin. Now we're going to check another video.
In this video, let's have a look at the difference in mechanism of action of high molecular weight heparin, low molecular weight heparin and fondaparinux. High molecular weight heparin, as the name suggests, it has a higher amount of polysaccharide units. And all the heparin molecules contain a pentasaccharide unit which binds the antithrombin. Upon binding of the antithrombin to this pentasaccharide unit, the antithrombin gets activated and further binds the activated factor 10A and finally inactivates this activated factor 10A. As this high molecular weight heparin is a very long molecule, it also tethers the activated factor 2A along its length, and the activated antithrombin inhibits the factor 2A also. As heparin is a very long molecule, it binds both antithrombin and factor 2A so that it inhibits the activity of both activated factor 10 and activated factor 2 in almost equal ratio, that is 1:1 ratio. Moving on to the low molecular weight heparin, it almost always binds the antithrombin and inhibits the factor 10A. The mean polysaccharide units in low molecular weight heparin is around 17, whereas for tethering of the factor 2A more than 18 polysaccharide units are required, and therefore some of the molecules of low molecular weight heparin binds this factor 2A and deactivates the factor, whereas the other molecules are too short to bind the factor 2A and therefore inhibits only the factor 10A. So that the ratio of factor 10A to factor 2A inhibition activity is around 2:1 or 3:1 depending upon the type of preparations. Fondaparinux is a synthetic pentasaccharide of the antithrombin binding site so that it binds only the antithrombin, and finally inhibits only factor 10A activity. As it is too short and binds only antithrombin and inhibits the factor 10A activity, the ratio of inhibition of factor 10A to factor 2A activity is 1:0.
Now we're going to see the last video explaining something about heparin-induced thrombocytopenia. Thank you.
Hey guys, today we're going to talk about heparin-induced thrombocytopenia, but before we get into that, let's just cover a little bit about heparin itself. So as we know, heparin is used as an anticoagulant agent which inhibits thrombin, and it does this by activating antithrombin 3. So let's say we have fibrinogen, which gets converted to fibrin. And fibrin is one of the main important components of the coagulation cascade, right? So we don't want to make this fibrin. And in order for fibrinogen to get converted into fibrin, we need thrombin. So if we give the patient heparin, heparin will activate antithrombin 3, which will then inhibit thrombin. Therefore, we're gonna have inhibition of fibrin production. Heparin is also an immediate anticoagulant with a short half-life. Therefore, we can use it in conditions such as pulmonary embolism, stroke, DVT. We can also use it in pregnancy since it does not cross the placenta. And some of the important side effects of heparin are obviously bleeding, because we are inhibiting production of fibrin, osteoporosis, so if we have a patient who already suffers from osteoporosis, we obviously don't want to give her heparin. Instead, we can give her another drug in the heparin family, which is a low molecular weight heparin, and it's called enoxaparin, which does not cause osteoporosis, okay, which is a high yield point that we need to know. Okay, so enoxaparin. And lastly, another important side effect is heparin-induced thrombocytopenia, which we're going to talk about now. If someone receiving heparin develops a new or a worsening thrombosis, or if their platelet counts falls, we can assume heparin-induced thrombocytopenia. And here's why. Now, sometimes heparin acts as a hapten by binding to platelet factor 4. So here's our heparin. Okay, it binds to platelet factor 4 and it forms a hapten, which will then stimulate the immune system, resulting in antibody production. Okay, so our immune system gets stimulated, and then we start making antibodies. These antibodies are usually of the IgG class, which will form a complex with heparin and PF4, which is our platelet factor 4, in the bloodstream. So let's just imagine that this is our IgG binding to heparin and platelet factor 4, forming a complex. Okay. Now this results in platelet activation, which initiates the formation of blood clots leading to decreased platelet counts and eventually thrombocytopenia. So if we have a patient who suffers from HIT, he or she will be in a hypercoagulable state